So role of albumin is well accepted in different clinical scenarios. For example, in patients with hepatorenal syndrome, in patients with spontaneous bacterial peritonitis, for removal or large volume paracentesis, in patients who requires plasmapheresis as replacement fluid. But role of albumin in septic shock is still not widely accepted or still not being used very widely. Let's see the role of albumin in septic shock in this small video. Let's see the role of albumin in the salvage phase or the rescue phase of resuscitation, where the patient is in imminent danger to life. And the albumin has been shown to be beneficial, to be safe. I'll not say beneficial. It has been shown to be safe in large multi-center SAFE trial. So compared to patients who were resuscitated with 0.9% saline, albumin or 4 to 5% albumin was found to be as safe as 0.9% saline. However, in the SAFE trial subgroup, patients with coexisting traumatic brain injury, it is not safe at all. So patients in whom there is no coexisting traumatic brain injury, we can use 4 to 5% albumin for resuscitation in salvage or rescue phase. However, cost-benefit ratio must be analyzed because it has not been found to be better compared to 0.9% saline. In the optimization phase, where the patient is not in imminent danger to life, but perfusion is still not achieved, and we need to give some fluid based on the fluid responsiveness parameters or fluid tolerance parameters. Use of hyperoncotic albumin may be beneficial in limiting the cumulative fluid balance. And this has been shown by the small 4-center Australia and UK based SWIPE trial. However, again, this evidence needs to be substantiated by larger trials, and cost-benefit ratio must be evaluated. Thirdly, in the stabilization phase, where we don't need fluids for resuscitation, 20 to 25% albumin infusion, targeting a serum albumin of more than 3 grams per deciliter may be beneficial, may decrease mortality in patients with septic shock. This is based on a weak evidence from the subgroup analysis of patients of septic shock from LBOS trial. Again, this evidence needs to be substantiated from a large trial, specifically looking for this goal. And again, cost-benefit ratio must be analyzed before widely implementing this strategy in stabilization phase. Compared to the earlier 3 phases, in the de-escalation phase, we have more evidence favoring use of 20 to 25% albumin along with diuretics or ultrafiltration. In the de-escalation or evacuation phase, patients are all bloated up because of fluid overload, and fluid overload itself is causing more damage to the patient's organs. Here in this phase, addition of albumin along with diuretic or ultrafiltration with an aim to remove fluid without causing much harm to the patient, maybe albumin has got some role. Albumin addition can produce greater fluid removal. At the same time, it can maintain intravascular volume in patients who are getting diuretics or ultrafiltration. So these are the this is how we can summarize the role of albumin in patients with septic shock.